Hello and welcome to the Space Madness podcast. This is your host, Jeff Nosanov, and today we're going to talk about space medicine. A really interesting subject to me. Just the longer you think about human space travel, the more important it is to actually know what happens to us out there, and it's a lot. So I'm excited to have an expert guest with us today. So our guest is Dr. Octav Cristea, assistant professor at Emory University, a transplant surgeon and urologist. So that's a lot already. So why don't you introduce yourself a little more if you want to add on to that, and we can get started.
Sure. Well, thanks very much. Thanks for having me on. So yes, like you mentioned, I'm a transplant surgeon here at Emory. That's what I do as a clinician. So I have a practice that focuses on kidney and pancreas transplantation and living donor kidney donation. But I arrived at this via the pathway of first becoming a urologist, which is a little bit unusual in the U.S. Most transplant surgeons here are general surgeons, but I did my residency training in Canada. And so I kind of pursued urology to become a transplant surgeon. Urology is the medical and surgical specialty that deals with the kidneys and genital urinary organs. But in addition to my clinical work, I also have an array of research and academic interests, and some of that pertains to bringing urology to bear on the transplant population and looking at renal and GU issues in the transplant patients. But some of that taps into one of long-standing passions and loves, and that's human spaceflight. And so I've been lucky enough over the past few years to do a lot of work in aerospace medicine, specifically looking at how renal and genital urinary issues come up during spaceflight and what we do about them when they do.
Okay, yeah, that is. I mean, I'm really interested in learning more about that. As I like to do in this podcast, I want people to see themselves from all different kinds of backgrounds and career paths and educational preparation. I want people to see themselves in space exploration. So, if you will, I'm curious how you found your love of space exploration and how you kind of maintained that, kept that, and finally got to apply it here in this genitourinary field of medicine.
Sure. It's very definitely a circuitous route. I think, in terms of how it all started, I think a lot of these, lifelong passions, when you have them, coalesce sometime in childhood. I don't know that I can point to any one specific thing, but if I had to pick one influence, it would probably be my dad. He was a mechanical engineer, nothing to do with the space program. This was in Romania, where I was born and spent the first few years of my life. That wasn't really kind of an option open to him, but he grew up watching the Apollo missions, and he told me stories of waking up in the middle of the night to watch the Apollo moon landing. It kind of absorbed a lot of this interest and passion for him. I have these vivid childhood memories of being out with him at night, especially when we would go out to the countryside and you didn't have the kind of the ambient light pollution, and you could just see this brilliant night sky. And it was absolutely captivating. I think it kind of captured me then, and it never really let go. So then as I grew up, you had me read Arthur C. Clarke and Asimov and some of the old school hard sci-fi. And I think initially I had this very sort of linear thought of I'm going to be a military pilot, and then I'm going to be a test pilot, and I'm going to try to join the space program, kind of the Chris Hadfield route. And by the time I was in high school, it became apparent that probably wasn't going to happen, mainly because I had to wear glasses.
Okay.
At the time, the Canadian Air Force didn't allow corrective vision for its pilots, and so I had to figure out a bit of a different path to pivot. And so in undergrad, I ended up gravitating towards human anatomy and medicine, and in particular surgery. I knew pretty early on that I wanted to do surgery. Again, some of this stuff has to do with just who your influences in your life happened to be at the time. I had some really great anatomy teachers. They had a phenomenal anatomy program where I was at the University of Guelph, and so to me, it didn't seem like that much of a pivot, in the sense that I was still seeking out something where I could work in physical space. And I had a pretty good sense of not just what I wanted to do, but the kind of person ideally I wanted to be. So I had this ideal of somebody who can make good decisions under difficult circumstances. And I had kind of grown up idealizing that, or idolizing that, I guess. And so I thought, well, if I can't do aviation, I could probably find that in surgery. And so that
Okay.
I think that kind of drew me in that direction. So psychologically,
Okay.
it didn't feel like that.
Interesting. So it sort of was your intrinsic drive to seek out these very challenging situations, it sounds like.
I think so. Going back to my dad, I think that's something I absorbed a little bit from him as well. He was this kind of understated guy, didn't like people who were loud and showy, very much the archetype of the quiet professional.
Mm.
And he always he perceived the kinds of people who worked in the space program to be that, to mold.
Okay, I see.
That was the ideal. That was the kind of person who
Yeah.
did this. And
Yeah.
so what I got from him is not just here's the thing I want to do, but I want to be the kind of person who would do that kind of thing.
Right. Right. I really love that because it makes me really happy to hear about that impact of American leadership, particularly early human spaceflight. And obviously the whole world was watching, but to hear of one single person watching and that impacting him, that is
Well, I have memories of, drawing, the space shuttle as a kid
mhm.
and, trying to write NASA, but kind of garbling the letters because at the time I didn't speak a lick of English. So I didn't know what any of it,
Okay.
but,
Sure.
but I asked my dad, I'm like, is this order correct?
Yeah. Yeah.
So, it's funny
I
that,
love that.
we were certainly on the wrong side of the Iron Curtain, but,
Mm.
these kinds of moments in history can really reach people and transform them.
Wow. I love that. And clearly that really kind of got into you at a very low level, like a base layer almost of all your later aspirations and education. It all kind of built from that. And I can relate to that. And I think I see why to you it wasn't much of a jump between piloting and surgery, because they both were kind of on top of this fundamental level of kind of aspiration and goal. So I really like that. It's one of my favorite things about space exploration is that it really challenges us at a very deep level, almost at a, well, not almost, at an actual survival level. And I like to imagine future long space journeys bringing the best out of people, both cooperation and partnership, but also the extensive engineering and technical understanding that we as humans put our minds to and can do so well. Anyway, I could ramble on about that for a long time, but I get very philosophical. So space medicine. So you get through you're in the middle of your training. You've decided to do surgery. When did you have your first real impact to actually do space medicine work?
It didn't really come up until I was my first year of residency. So when I got into medical school, it wasn't really on my radar. At that point, I was pretty focused on just pursuing a career in transplant, and so I picked urology again. I had some really phenomenal mentors, and realized pretty early on that I wanted to be just like them. And so it didn't give much thought to space medicine per se. But then when I was in my first year of residency, the bug kind of bit again. I thought really hard about how could I incorporate this? How could I incorporate this other thing that I love into my career trajectory? And it would have to involve something like urology or what I was doing, because
Sure.
as you know, residency is like this all-consuming experience. There's just not much room for anything else. And so I was at a coffee shop one day, and I came across this copy of this textbook called Principles of Clinical Medicine for Spaceflight, which is one of the leading textbooks in the field of aerospace medicine. It's the brainchild of, Mike Barrett, who was a physician, then became a flight surgeon at NASA for many years, and then was ultimately selected to the astronaut program. And I flipped through and I said, there's a renal and GU chapter, and so
Okay.
sure, let's nerd out about that for a little while. And it turns out that there is a lot that urology can bring to bear on this topic. So there's kidney stones, and there's urinary voiding issues and so on, and stuff that we'll talk about. But I looked up the author list, and the first author was a surgeon at University or at Baylor College of Medicine down in Houston, and he's a urologist by training, and also for many years had been a NASA flight surgeon. And so I thought, well, phenomenal. So long story short, I tracked down his contact info, and I sent him an email. And to his great credit and to my sort of eternal gratitude, he responded. I feel like I'm sort of in retrospect even more appreciative of that now that I'm faculty, because I get blasted with like 100
Hmm.
a day. And so it would have been, you could imagine it would have been very easy for my random email to just end up in his junk folder.
Sure.
Took the time and corresponded with me, and we spoke a little bit. And then ultimately we arranged for me to do some clinical rotations down in Houston so that I could kind of fulfill the requirements for my residency, but also
Sure.
get on board with some research work that he was doing. And again, sort of having the right people in your life. My residency program and the program director I had at the time in Ottawa was very supportive. A lot of other folks would have kind of laughed you out of the room if you came with that proposal,
Sure.
but took it very seriously and really worked with me to make it happen. So I spent a summer down in Houston, and then that eventually led to an ongoing collaboration. So,
Mm.
I should say I don't practice space medicine myself, so I'm not board certified in space medicine. I'm not a clinician, but I've been fortunate enough over the past decade or so to correspond with and think about these issues and work with some of the folks who do and some of the ones who have been to space themselves.
Is there actually a board certification in space medicine?
There is, yeah.
Oh, that's awesome.
It's its own specialty. There's a few
Uh-huh.
programs across the U.S., some civilian, some military. Some
Ah.
are more aviation focused, some are more space focused.
Hmm.
It's through the American Board of Preventive Medicine. So it is its,
Okay.
if you actually want to practice space medicine, which involves kind of
Yeah.
flight crews and so on,
Yeah.
there's a separate training pathway that you can go to do that. So that's what my mentor Jeff, he
Okay.
was a urologist at first, and because they were having trouble with stones and astronauts and some of these urologic issues, he became
Okay.
involved and ultimately trained as a flight surgeon as well.
Okay.
He was a flight surgeon in the Navy as well. So he did both kind of the aviation and the space side of things.
So kidney stones scare me on the ground.
Yeah.
I'm sure that is even worse up there. But before we get into that, the urogenitary stuff specifically, I want to. Something I often think about is that basically, as soon as an animal leaves the planet, you're basically daring the universe to kill you or
Right.
challenging the universe to
Yeah.
kill you. We're
Yeah.
really not supposed to be up there. We're really barely supposed to be above the trees. We're pretty good at trees, but the sky and space, it's a pretty amazing we get up there at all and
Yeah.
mostly come back. So, I mean, what is the biggest threat to the? I mean, I'm trying to think of a question that doesn't have a million different answers, but in our current knowledge, what is the biggest threat to human health in the microgravity environment?
Hard to pick just one, but
Okay,
let me answer your question this way. Let me
sure,
give you a big picture sense of why this environment is as different
sure,
from the earthbound environment that we evolved in.
okay,
It's exactly like you say, right? There's probably no other environment that we can access that kind of deviates more sharply from the conditions that we evolved to optimally function.
yeah,
Right. And when you think about the spaceflight environment, there are kind of three major components to that. One is a change in pressure, right? So you're above, above the Armstrong line, which is roughly around 19 kilometers or so. Body fluids boil, and so you need a pressure suit to be able to survive. Or you need to be in some kind of pressurized vehicle. So that's one aspect. Two is a different radiation environment. So here on Earth, we're kind of in a radiation bunker, we're very well shielded from the cosmic radiation that is really just par for the course everywhere
yeah,
else.
everywhere, literally, yeah,
The
everywhere,
universe is basically bathed in it.
yeah,
So here we get a lot of protection. We get some degree of protection in low Earth orbit as well. We still receive some protection from the geomagnetosphere. So it really becomes much more of an issue when you venture beyond that. But it's certainly higher in orbit than it is on the surface. And then the third one is the lack of gravity, and that is probably the one factor that drives most of the physiologic changes that
Okay.
we think about during spaceflight. And we've been at this now since Gagarin flew in 61. So on the one hand, we've accumulated a lot of experience, but on the other hand, he flew 4 days after my mom was born. So I always like to say all of
Wow,
spaceflight is younger than my mom, who was not an old lady. And so if you kind of zoom out a little bit, it really is. It's a very recent thing, and we're still learning a
sure.
lot.
Well, and it's incredibly hard to get any data at all because you got to put someone in space first.
So that's right. So
Yeah.
in total, depending on how you count them, but if you just look at orbital flight, there have been just shy of 640 people, I think, as of right now, who have made
Hmm.
it to orbit. 80% of which have flown for about 20 days or less, because a lot of flights happened during the space shuttle era.
Yes.
And so if you imagine that is the totality of our sample size from
Hmm.
that's the basis upon which we've kind of tried to understand physiology in a completely new environment. So
Yeah.
given that, I mean, we really have done a lot, and I mean, human beings have basically been in orbit continuously for
Hmm.
almost a quarter century now. Actually, I think we've hit the quarter century mark because the space station has been continuously occupied during that time. So we have learned a lot, but there's still quite a ways to go.
So yeah, so getting to the urology subject, my understanding of kidney stones is it's a crystal growth of some kind, and I know from other experience that crystals grow differently in microgravity. I doubt they grow in a better way for us when they're inside our bodies. So where do you start with that?
Sure. So yeah, we can definitely talk about stones a little bit. So one of the things that happens when you reach orbit is that you are, by virtue of being in a weightless environment, suddenly there's almost an immediate redistribution of fluids in your body. Right?
Okay.
Your gravity is no longer pulling blood all the way down to your feet. So there's kind of this cephalad migration of fluids in your body. And so that's why you'll
Hmm.
often see astronauts have a bit of like a puffy look to their faces. And
Hmm.
that's the reason why. And so there are all sorts of downstream consequences of this. Your kidneys adapt to that, your
Hmm.
cardiovascular system adapts to that. Your bones and muscles are no longer being loaded, right? And
Hmm.
so that constant loading in gravity is part of the kind of equilibrium that maintains muscle strength and bone growth and so
Hmm.
on. When you take that away, you start to lose some of that. And so for kidney stones in particular, a couple of things happen. One is the absence of muscle loading causes leaching of calcium into the bloodstream. So your bones start to dissolve. There's something on the order of about 1.5% of bone mineral density loss per month in space,
Wow.
absent any kind of intervention or absent, some kind
Okay.
of countermeasure.
And that's why they have those interesting exercise machines on the station.
Yes,
Yeah.
exactly. And so when that calcium kind of dissolves from the bone, well, it has to go somewhere, right? And
Hmm.
it ends up getting filtered, and you end up having more calcium in the urine. Well, one of the biggest risk factors for calcium-based kidney stones, which is the most common kidney stone, is hypercalciuria, or an excess amount of calcium in the urine.
Hmm.
In addition to that, there are all sorts of conflicting physiologic signals that your body gets because of the fluid redistribution, stuff
Hmm.
that it's very interesting and complicated, but it's hard to tease apart. And so folks end up drinking a little bit less, so they're relatively more dehydrated. They end up producing
Huh.
less urine over the course of the first at least couple of months
Okay.
of base. And less urine, more concentrated urine also increases the risk of stone crystallization. And the last component is that fluid shift causes structural changes in the kidney itself. So there was a great paper
Oh.
just last year from it's a large multidisciplinary group, but it was led by a group at the University of College of London, where they basically looked at urine and blood samples and tissue samples from many space flights to the International Space Station over the past 20 years or so. Also, animal experience.
Hmm.
They tried to build this detailed picture of like what is actually happening to the kidney at the molecular level. And there are
Hmm.
all sorts of changes and adaptations that are happening, which also contribute to your kidney basically wasting more calcium. So all told, you end up, and even after a short period of flight, like we had in the
Hmm.
space shuttle era, your risk of kidney stone goes up significantly.
Okay. So you mentioned that people drink less water. That it sounds like they get less of that signal that tells us to drink water. I mean, can they just, at the risk of oversimplifying interventions, can they just be told you must drink this much water?
Yep.
I imagine that's just one of many variables.
Yep,
Uh,
absolutely. And so water intake is a huge part of it. And that's gotten better, especially with the life support system that exists on the space station now. They have pretty good access to drinking water, readily available. But what can sometimes happen, especially during early phases of flight, is that there's so much going on
hmm.
and things are so busy. A lot of people just forget. And
Really? Okay.
I'm guilty of doing the exact same thing during my busy surgical days.
Sure.
My wife is always harping on me about drinking
Yeah.
water, and I'm a terrible urologist in that regard because I don't really take all of my own advice.
Well, it's funny. I think that one reason I'd be a terrible doctor is I'm not very good at ignoring my own needs.
But for exactly like you say, drinking more water is a huge part of it, right? So the biggest way to try to mitigate this is to prevent it in the first place, right? So one of the reasons why selection criteria are so stringent, if you've ever had a history of kidney stones, you're basically out. You can't be selected to the program. Decreasing the amount of sodium content in food because high sodium foods are also a risk factor for kidney stone formation. They made a lot of
So
progress.
does that influence the food that's sent up there?
Yes, yeah. So they
Okay.
they made a very concentrated effort over the past few years to reduce the amount of sodium content in food. And then what you alluded to earlier, which is the exercise device. So they spend on the order of about 2 to 2.5 hours every day doing both cardio and resistance exercise, both to maintain bone and muscle strength, but also to partially, at least mitigate the loss of calcium from the bones. It's not perfect. It doesn't
Sure.
eliminate the problem, but it does take the edge off a little bit.
I mean, at the risk of, I mean, this is kind of an extreme idea, but is it? And I realize the body there's calcium floating around both from the food and from the natural processes. But what if they just have zero calcium in the food? Does that make any impact on the floating calcium around that that becomes a problem?
It's a good question. So actually, it's not really the calcium in the food that's the problem,
Okay.
unless
Yeah.
you really overdo it. And in fact, paradoxically, sometimes if you decrease calcium too much in the diet, that can also increase your risk of kidney stones for other physiological. So most of the calcium that's being lost in this setting is from leaching from the bones.
Yeah. Yeah. I should have known that we can't outsmart the body that well or that easily.
It is always trying to find some way to adapt to its new environment, and it's remarkably good at doing that.
Yeah.
Sometimes
In the short term, at least, right?
that's right, that's right, but and with lots
Yeah.
of unexpected twists and turns. But to give you one anecdote about this, one of the urine processor assembly, which collects urine on the space station, is very intimately linked up with the broader life support system, and so 85% of urine is reclaimed into drinking water. When they first started out, in short order, one of the components, the distillation assembly, failed. And when they brought it down and opened it up, they found that it was getting clogged up with all these calcium sulfate precipitate. Because in the design of this component, they had not adequately accounted for the excess amount of calcium in urine of astronauts. And so this was combining with a pretreatment solution, with a sulfuric acid pretreatment solution, and forming these calcium sulfate precipitates. So they had to actually change the design and the solution that they used in this component so that they could actually work this thing to its full potential. But in effect, the space station got its own kidney stones, which is
Wow.
the space and urology nerd kind of amusing
Yeah.
to no end.
Wow. Yeah. I mean, was that because when they designed the first version of it in the 90s, I assume that it wasn't an understood phenomenon yet?
It was. I mean, I think we've known about the risk of kidney stones in spaceflight, really since the Skylab missions. I think, if I recall correctly, I think that's when some of the first detailed measurements of calcium balance in the body were done. And it was hypothesized even before that. But in the design of this component, it just wasn't really factored in that much calcium in the urine would combine with this particular pretreatment solution to form these would then clog up the works.
I see. So now having been part of NASA teams, I can see how that conversation might not have happened between different groups and different places.
Yeah, or maybe nobody even. I mean, maybe nobody even had the thought because it's one of it's the 10th million thing.
Sure.
And the number of things you have to consider.
Interesting. I love that phrasing that the space station itself got a kidney stone. That's how bad it is. That's how serious it is.
That's right.
So you can adjust diet. You can add basically an exercise regimen to reduce the loss of calcium, reduce the amount of extra calcium that's floating around their bodies. I mean, what else can you do?
So the next line is pharmacologic treatments. So there are a number of Well, there are two kind of main categories of pharmacologic therapy that have been studied for this as well. One of them is, is in combination with the resistive exercises that we talked about. The Japanese space agencies did a recent trial using bisphosphonates, which are a class of
Okay.
drug that are used to prevent osteoporosis and to prevent the breakdown of bone. And
Okay.
so when you combine bisphosphonates with exercise, you can pretty significantly reduce the amount of
Interesting.
calcium in the urine.
Okay.
Whether you do this for everybody and whether you do it long term is an open question because, of course,
Okay.
these drugs have their own potential side effects. And so you always have to weigh the risk of a kidney stone and what the potential impact that would be on emission versus the risk of a side effect from the medication. And that's not always obvious to tease out.
Sure.
There's another drug that's used very commonly in the treatment of kidney stones, which is potassium citrate, a randomized double-blind trial on the Mir and the International Space Station, administering this to astronauts and then, observing their urine parameters after. That was demonstrated to be effective in kind of normalizing some of those parameters in the urine that indicate an increased risk for stone formation. So that's actually
Okay.
so potassium citrate is one of the approved countermeasures that they'll use now in practice. So, for example, if there's an astronaut that has had a stone or is at high risk for a stone,
Okay.
and they get a waiver to fly, they might be
Ah.
given potassium citrate to take.
Now, how long does a person have to be in that environment before this starts to add up to something concerning?
Good question. So hard to say for sure. I mean, if you look at, thankfully there haven't been any episodes of stones on board the International Space Station to date. There's one episode of a kidney stone that occurred in a Soviet cosmonaut, and
Interesting.
it passed spontaneously, and it didn't require an evacuation from.
Okay. Wow.
But if you look at the overall prevalence, if you look at folks who flew and then all of these astronauts are tracked, basically for
Right.
life after.
Yeah.
The prevalence, there have been over 40 stones now in something like 29 individuals or so at last count, out of a
Okay.
total, astronaut population of about 360.
Okay.
You're just under what the kind of general population prevalence is in the US, which is about, 9%. And that's quite high, actually, because you'd expect that a very carefully selected population
Okay.
that is screened for kidney stones at the time of selection, it's going to have a
Yeah.
much lower prevalence rate, same as you see in
I
pilots,
see.
for example, and so on. While it's hard to kind of put an exact number on it, the thought is that after an ISS mission, your risk for developing a kidney stone in the first year after that is roughly 2 to 7 times what it was before
Interesting.
of the baseline.
And
during
that's for
flight
like,
itself, it might be up to double that.
so that's like for the average couple of months stay.
Correct. Yeah. Yeah.
And now we're talking risk, so that could be 0.0001 to 2, right?
In
So
absolute terms,
yeah, in that way, that sometimes people struggle to really grasp that a doubling of risk it might not be nearly as scary as it sounds.
that's true. That's true to a certain
Yeah.
extent. Now, when NASA has this statistical medical model that they basically tried to, all the data that they've accumulated from flights to date, plus specific mission parameters, they try to plug it in and they try to get a sense of how likely is something to happen.
Sure.
What's the risk of a medical emergency? And when you run the simulations, kidney stones are usually one of the top risks for a potential premature deorbit for medical evacuation. Now, that's in a setting where you are in low Earth orbit and you can medically evacuate.
Yeah.
Once you start talking about something like a trip to the moon or anything beyond orbit, that's no longer an option. And one of the thing about urologic issues, or really any issues in spaceflight, is that even simple and straightforward issues become vastly more complicated if they're happening in that environment.
Yeah.
And so if you can't prevent a stone, then the next question you ask is, okay, well, what do you do about one if it actually happens on orbit? How do you manage it?
Yeah. Well, I want to get that answer too, but you're really making a strong argument here for rotating space stations that have some equivalent of gravity,
Oh, yes.
whether it's 1G or less. But But of course, that increases the cost by another cube. But sounds like that may be
Well,
necessary.
and related to that, one of the issues is not just adaptation to microgravity, but then adaptation when you're reintroduced to gravity, right? And so you have to imagine, let's say you embark on a trip to Mars, right? And you spend a few months getting there, and then they land. Well,
Yeah,
just how quickly can their bodies adapt to in Martian gravity?
yeah,
Their cardiovascular system, their vestibular system, their ability to kind of maintain their balance,
yeah,
ability to maintain their blood pressures. A lot of, if you've seen these videos, especially from when they land in the Soyuz, there's all these folks kind of carrying them out and
yeah.
putting them on these
Well,
chairs. They're always looking straight and not turning their heads because you turn your head and then your vestibular system goes haywire. So having some degree of gravity stimulus along the way might go
yeah.
a long way towards kind of
Well,
mitigating that intolerance.
so that gives me an idea where imagine you have a space station variable rotation or a vehicle with a variable rotation rate, and someone like you figures out, okay, if we're going to go from 1G on Earth to, I think it's like 1/3 of 1G on Mars. Yeah, the moon is 1/6. I think Mars is 1/3. There must be an optimal curve of adjusting the gravity over a 9-month journey if you're
Great
lucky in
question.
9 months. There must be an optimal. I mean, that's not great for anyone. Optimal would be to stay here, but if you're going to go, there must be an optimal adjustment over a 9-month period to
Yes.
get people ready for that, and then the reverse if they come back. But
Yes.
again, that's another $1 trillion.
Well, so one of the interesting things is we right now we've gotten very good at understanding physiology in 0G,
Mm,
and we understand physiology in 1G quite well. We don't know much of anything about the in between. So mapping
mm,
out kind of that partial G curve is going to be a major area of study, you know, in the coming decades as we go back to
yeah,
the moon and spend time in partial gravity. And
yeah,
the $1 million question is exactly like you said, is how much gravity do you need for it to be enough? We know that with pressure,
sure,
for example, you don't need to be at full pressure. Sometimes just, a quarter of the regular amount is enough to be able to say go out and perform a spacewalk. And so the $1 million question is how much partial gravity would be enough to mitigate some of these problems. I heard this in a presentation once, but I'd
mm,
never really thought of it this way. Every interesting place that you can stand on in the solar system
mm.
has a gravity of less than 1G. So mapping out this.
That you can stand on and survive.
Correct. Yes,
Okay,
that you're likely to stand on at any time in the
sure,
coming centuries. And so mapping out this physiologic gravity curve, is going to be
yeah.
a big part of this kind of study moving forward.
Yeah, fascinating. Okay, so the next thing you mentioned is voiding. So I assume that just means just peeing, right?
Correct.
That's the medical term for peeing. Okay.
That's right.
So
Yeah, emptying your bladder.
so never really occurred to me that I guess that's the relaxing of muscles, right? Like so in a microgravity environment, do all those one of the things I find most interesting about weightlifting and the human body is that the muscles are in opposition to each other, right? Like
Hmm.
one has to relax, the other one can contract. So I would imagine that's happening in the urinary system too, to some degree,
Correct.
right? I mean, if you'll forgive the oversimplification. So what exactly is happening in there when we're in microgravity?
Your intuitions are exactly right. There's a combination of things that involves both the relaxation of certain kinds of muscles and the contraction
Mm,
of other muscles. So in order
okay.
to properly void, and to do so in a way that doesn't hurt your bladder and your kidneys and that it's all smooth and coordinated, your sphincter, which kind of
Mm,
keeps things contained and keeps the urine in the bladder
mm,
where you want it to be when you're not emptying, has to relax. At the same time, the detrusor, the bladder muscle, is squeezing so that it can push the
mm,
urine through. And all of this is a very complex interplay of physiologic and neural signals in kind of in
mm,
normal circumstances. One of the things that seems to happen in 0G is that you lose some of the sensation to void, at least initially, at least while you're adapting.
uh,
And so they've known this, that there's this decreased urgency to void from initial experiments with parabolic flight. So in the 1950s, they took volunteers with full bladders, had them go up on these parabolic flights. And during the 0G phase, what they noticed was that urgency to void would decrease.
Yeah. Sorry, I'm just imagining chugging a couple bottles of water while taking off.
Yes. Yeah, absolutely. You can imagine what
Yeah,
that
yeah.
like for all involved. But
Wow.
one of the things that happens is that all liquids, once you take away gravity, the force that kind of dominates their behavior is surface tension.
Yeah.
And you see all these videos of astronauts doing funny things with water, right? And it behaves
Are you saying that happens inside the body too?
Yes, well, because your bladder is this, instead of, say, urine collecting at the base of the bladder, the trigone,
Yeah.
and which is a very sensitive area, which has a lot to do in terms of the sensory input that goes to tell you, hey, you're
Of
full.
course.
The bladder's just kind of the urine is kind of collecting along the wall of the bladder, and so
Wow.
your bladder's probably going to get a lot fuller before you get the first sensation to void. But getting full and overstretching
Yeah.
can also disrupt the ability of that muscle to properly squeeze.
Wow.
And so there have been a number of cases of astronauts, especially during the early phases of flight, going into urinary retention where they can't empty their bladders. So one of the standard items on all the medical kits is a variety of catheters, so that catheterization can be performed if needed, which it has been on multiple occasions.
Wow. So that just gets to a philosophical point here that something as basic as peeing, and I'm deliberately avoiding the medical terms here because my point is the fundamental nature of our bodies and
Very
biology
basic.
of every mammal, at least on Earth, probably most other animals too, can't even pee right up there.
Correct. Well,
Man.
you know what? What's funny is that this goes all the way back to the first mission. So Alan Shepard, the first American in space, he was due to go up for a short 15-minute parabolic flight up and down. But there were a number of delays on the launch pad. And so I think he ended up waiting something like 8 hours before he launched.
Oh, that's right. Yeah, I remember that story.
And so nobody had actually planned for or thought about what he would have to do if he had to his bladder. And so there he is lying recumbent, and he tells mission control, and eventually they all kind of look at each other and say, well, just go ahead and pee in your suit.
Yeah.
And so sure enough, absent any kind of like waste containment system or diaper or anything like that, he voids in his suit. And so you can imagine where that urine tracked, and it short-circuited a bunch of his biosensors as a result. And so they learned from that, and for subsequent missions, they designed ways to kind of contain the urine. But it was an issue again at the very, very dawn of spaceflight. It's just you would think it'd be the most basic thing to think about, but
yeah. Well, that gets back to sort of this tension that is so fascinating to me of our fundamental drive to explore, which on Earth doesn't really affect where you go to the bathroom, but I'm aware there's a story that Buzz Aldrin, when he exited the Apollo 11 capsule, and I'm 99% sure this is true. Basically, that the Apollo 11 Neil Armstrong landed so well that a crumple effect that was designed into the legs, assuming they was going to hit harder than it did, that didn't crumple, and so the ladder they were going to climb down was higher from the surface than intended. Because the whole thing was supposed to crumple a little bit, the legs. And Neil Armstrong kind of shimmied down the ladder, but apparently Buzz Aldrin jumped. Jumped is kind of a relative thing in lunar gravity. But my understanding is that when he landed, it broke. He hit the ground with his spacesuit a little harder than intended, and it broke some tubing, and some urine that was had been captured somewhere in the way it was designed, basically flowed down to his boot. And so his first step on the moon was with a boot full of urine.
That's it. I wasn't aware of this. I wasn't aware of that.
And I'm accuracy is important to me. I'm going to look that up before I'll probably keep it in the recording, but I'll put it in the notes if it turns out that's not true.
Let me know, because that's a great story if it's true. I hadn't heard of it.
I'm pretty sure it's true. But the point being that we cannot escape our biology and physiology anywhere.
No, and I mean, one of the other issues, urinary retention is its own problem, of course. If you have a full bladder, you can't function. I mentioned there have been a number of instances where astronauts have had to be catheterized, either in the early phases of spaceflight or, there have been some later episodes, all associated with spacesuit use. So after spacewalks. a variety of potential reasons as to why that was. One of
Interesting.
the things that this puts you at risk of is developing a urinary tract infection, because of course urine that is in stasis and that doesn't leave your body is a growth medium for bacteria.
Okay.
And so there have been a number of urinary tract infections both aboard the space shuttle and the space station. I mean, there's a famous one in the Apollo era. Fred Hayes developed a pretty bad Pseudomonas urinary tract infection, thought to have been secondary to prolonged use of urinary collecting device, which had kind of like a condom catheter appliance, which a lot of the devices use if you don't have kind of like a built-in space toilet. But he wasn't successfully treated until he returned to Earth. And so in that model that I mentioned earlier, where one of the top risks for a premature deorbit or for evacuation is kidney stones, right behind that is sepsis or systemic infection, with sepsis kind of being one of the main components. And the Russians actually had this happen. One of their cosmonauts developed a really bad prostatitis, which is a urinary tract infection involving the prostate, and had to be evacuated midway through a long duration mission.
Well, it sounds like there's no shortage of issues, known and unknown. So what does the next 5-10 years of this kind of work look like?
So a little bit of that I kind of alluded to already, which is once we're doing things beyond low Earth orbit, once we're back on the moon, really trying to understand and map out the response to the physiological response to partial gravity. And I think that will inform a lot about how we think about and plan missions if we ever venture to Mars or further. In terms of missions beyond low Earth orbit, right now, you have the International Space Station, which is the size of a football field. Spaces are only going to get smaller, more constrained. Volume and mass are going to come at an increasing premium. And so in addition to preventing these kinds of medical emergencies, you're going to want to have good countermeasures for dealing with them if they do arise, knowing that, realistically, medical evacuation might not be part of that. So to give you just one example of that, as it pertains to kidney stones, one of the exciting technologies that has come out over the last 10 years or so is something called burst wave lithotripsy, which is essentially a team from University of Washington in Seattle at their physics laboratory. They're using a NASA grant. They basically developed this tool, or I should say, they modified a conventional ultrasound probe to deliver pulses transcutaneously, just by kind of placing it on the skin, so that they could move and fragment a stone. We already do something like this called lithotripsy with much larger devices, but it's not something that we currently do with a handheld device. And being able to have something like this aboard a spacecraft, which is small and portable, would be a game changer in terms of being able to deal with something like this if it happens, say, partway through a Mars mission.
Did you say it uses ultrasound?
Correct. Yeah. And so it's the regular conventional ultrasound. I mean, they have an ultrasound machine on the space station right now. So that capability already exists. So this is really just modifying that to be able to direct and fragment stones. And it's currently undergoing human trials right now. I wouldn't, I have no relationship to this company or to the lab, but I would say just from following the literature, I wouldn't be surprised if this ends up in use in clinical practice at some point.
Sure.
That's probably the kind of solution that you're thinking of, in terms of missions beyond low Earth orbit. If you're thinking about closer to home, the big relevant developments there are that access to low Earth orbit is going to become cheaper and cheaper.
That's true.
And that means that the kind of person that gets to fly is going to have a very different profile than the professional astronauts that have flown to date.
Okay.
So this is pretty preliminary, but if you look at the Virgin Galactic flights, as of June, when they presented this data at our recent space medicine conference, of the first 33 folks that they flew, about 70% were male, and just over 40% were above the age of 60. Right?
Do you mean Blue Origin?
No, this is just a suborbital Virgin Galactic.
Oh, suborbital. Okay,
correct,
Virgin Galactic.
Yeah,
okay.
And so I haven't seen any data yet for who SpaceX and Blue Origin has flown in the private space. But just if you use the Virgin Galactic as kind of as a starting point, you can already see that the demographic of your crew is already starting to change, right? So it's going to be older. They're going to be a different kind of medical history that might have ruled you out, say for the professional astronaut corps. And Scientific American had this great article, I think at the beginning of this year, where they looked at everyone who's ever flown. And if you look at the median age at the
Coming
dock
down.
spaceflight,
Yeah. Oh, it's going up.
that's right. So median age
Yeah.
spaceflight was in the early 30s. Now it's about 50.
Yeah.
So it's steadily
Wow.
climbed up, and the age range has expanded
Yeah.
dramatically. So I think
I
that
imagine.
would be a big kind of thing for mission planners
Yeah.
to focus on.
Well, I imagine it has some applications to aviation in general also. As a sort of an observation that someone might look at this and say, this is such a small number of people. It's an obscure area, but it's a growing area. I think that's the theme I would like to end on, is that space medicine is growing and a great field for people to get into. But I think it would also, some of these things, perhaps not the total microgravity, but some of these things will apply to aviation too, I think, particularly the long-term radiation exposure, which has already been recognized in aviation. At least that's the last time I read about it, a long time ago. That
And I mean,
for some of the pilots with,
sorry, go ahead.
go ahead.
I was
Well,
gonna say,
just that some of the pilots with decades of flight, have measurably elevated radiation exposure just from being higher in the magnetic field for a long time.
well, and if you go to the Aerospace Medical Association conference, I think it's probably fair to say that more sessions overall are focused on various aspects of aviation, whether it's civilian or military and so on. That's a huge, branch of aerospace medicine that we didn't really even kind of touch on today.
Sure, sure. Well, I really want to thank you for joining me today. This has been very interesting, and I'm sure we've barely scratched the surface of how we're really not optimized to go up there for a long time. I want to thank you for joining me today, and maybe we'll do another episode in a year, see what's changed. Maybe when there's some Blue Origin data or SpaceX data, that'd be an interesting subject as well.
Absolutely. I would love that.
So thank you again for a fascinating discussion. And we'll see you next time on the Space Madness podcast.
Thank you so much. Thanks for having me.
Take care.